One of the key contentions in the conviction of Lucy Letby was that she deliberately injected air into infants on the neonatal unit at the Council of Chester where she worked. If you're looking at the screen now, you can see that several of the infants in the case were alleged to have been harmed or killed via air embolus or air via nasogastric tubing. Now, Dr. Evans has since changed several of these diagnoses and indicated that he no longer believes what he said he believed during the court case. But we're not going to deal with that today. It's been dealt with in previous videos, and I'll be making more videos on this topic in the near future. This particular video is simply going to look at the logistics involved in this so-called injection of air theory. The first thing to note is that the syringes that were cited by Dr. Evans have to be irradiated in sterile packaging. This means that they're wrapped in cellophane and must be wrapped in cellophane if they are to be used safely. You can see an example of this on the screen now, a sterile syringe that's wrapped so that it's suitable for medical work. So in order for Lucy to inject air as has been alleged, she would need to gain physical access to a syringe without disturbing anyone at any time on what is usually an extremely attentive and busy unit. So she'd need to remove the syringe from its packaging while there were nurses often attending to other babies in adjacent incubators or at least in the very near vicinity. Often there are doctors in the room, there are parents coming in and out of the room, and she'd have to do this, draw up the air to make the injection, and as we'll see shortly, make possibly several injections, and even this is highly dubious. So immediately that's a logistical issue, and it's difficult to see how that would be overcome. The next thing to consider is that infants on a neonatal unit are in incubators, as pictured here. So this would require her to remove the lid of an incubator, reach into it, take the infant out, somehow inject air, although even Dr. Evans, when speaking in court, wasn't even clear on this point or how it occurred. And she'd need to do this multiple times without being detected across multiple infants, because there are serious question marks about how much air would need to be injected in each case and the feasibility of this, even if there is no one else around. So it's becoming an even more difficult logistical task before you look at anything else at all. It's worth mentioning as well at this point that if you're going to do this, you could just simply smother the child. There's no allegation that any of the children were smothered. Dr. Evans looked at this possibility at one point, but ruled it out because the clinical picture couldn't be made to support that. So we know that Lucy did not smother infants on the unit, which is why Dr. Evans settled on this fantastical air embolism injection of air theory. So this is, in itself, it's an inefficient way of attempting to murder because it's unlikely to be successful, and of course it's much more difficult to do than smothering. So one of the things that was repeatedly mentioned to me is that a significant amount of air, what was described to me as a pretty large amount of air, would be required to cause a significant air embolism. Infants have small amounts of air in them all the time, as we know from Professor Arthurs, who provided a study which indicated this, but this is known to be the case anyway. A small air bubble is not life-threatening to an infant. It's not life-threatening to anyone. So in order to create the really large amount of air that's required, you would usually need more than a small syringe. Now we know that small syringes are used on this unit. We're seeing on the screen here a 10 milliliter syringe that is rather small. In some instances, even smaller syringes than this were used. And when I spoke to nurses, they just said to actually generate the amount of air required with this type of syringe is quite possibly logistically impossible. And then not all of the air that's injected will actually go where it's intended. One nurse estimated that perhaps 1/3 of the air will actually be correctly distributed into the required location, which supposedly occurs with a 10 milliliter syringe. So someone described this to me as not ergonomically, mechanically possible, considering the size of the tube, let alone is it logistically feasible, considering the number of people around her. So I found this thread on Reddit in which there's some discussion of this, and it's noted here immediately that a few bubbles don't kill most people. Naturally, we are dealing with infants that are smaller than adults here, but it is nevertheless still unlikely that a small amount of air can have any impact whatsoever on an infant, let alone kill the infant. It's notable that the speed at which the air is injected is also significant. This poster here, this is on an Ask Doctors forum, and this was posted approximately 13 years ago now. The poster here notes that small amounts of air injected into the peripheral venous system eventually end up in the capillaries of the lung, from where they are usually absorbed. Even if they don't, a small part of the lung infarcts, which would not be a major problem. Here they mention the forming of froth in the right ventricle and its outlet, which we will discuss in future videos. This is another important indication that air was not injected, because there was no indication of this frothy blood that is formed when there is a large air embolism. And it goes on to mention some further details to do with venous air embolism and further specifics which indicate that it's highly unlikely that an air embolism could have occurred in these infants. Then another poster points out that if there was an injection into a peripheral vein, it would take hundreds of millilitres to be fatal. The air partly dissolves and the remainder is broken up into tinier bubbles, which are too small to block any significant blood vessel for a dangerous amount of time. If the air is injected much closer to the heart, as in the jugular vein or a central line, there isn't enough distance or time for the air to be broken up. It can arrive in the right heart as one big bubble. In that case, a couple dozen millilitres can cause cardiac arrest. In order for a tiny bubble to kill someone, you'd have to inject it directly into an important coronary or cerebral artery to block that artery and cut off circulation to the heart or brain, but that would be a lot easier said than done. So Dr. Evans relied on this indication that Lucy Letby had used a central line, but he didn't provide a plausible scenario in which this actually occurred. He just said, well, this could have happened, and then that could have happened, and this could have led to this, and that could have led to that. But as I've mentioned previously, there were big problems in his assertion because some of the physical manifestations of what he was asserting didn't appear, notably the frothy blood that was mentioned previously. And of course, pathologists have examined these infants, so there would have been signs of that, whereas he, of course, did not examine these infants. So moving on to the next comment on Reddit, this is a different post actually. It's mentioned here that the thing that can kill you is a fairly large amount of air injected into you all at once. So that again causes problems with the air injection theory, because we know that Lucy is supposedly using these very small syringes that only contain 10 millilitres, and some of these syringes used on the neonatal unit were even smaller than that. So not only that, but not all of the air is going to be injected successfully at once. So she's going to have to go back and make multiple injections of air, but as is rightly noted here, it will be broken down in a very short period of time. So it needs to be a large amount in a short period of time, and it is very doubtful that that's even possible. There's some further explanation here, but that's kind of the major point. The last sentence here is just, if air does get in, it's going to be a very little bit at a time, and it will dissolve in and then be expelled. So we'll go on to address that in further detail as the video continues. This poster here indeed notes that you need a pretty large syringe filled with air to harm someone with an air bubble. And this was something that nurses told me, that the syringe is very small. You can see the size of a 10 milliliter syringe here is only 5 or 6 centimetres of actual air if you measure the length of the syringe. This would then have to, in the case of the nasogastric tube cases, this would then have to be attached for an injection to be made. Then the syringe has to be removed. Then it has to be drawn up again while some of it's leaking out. The baby also naturally pushes this air out of its symptom, and then this would have to be repeated numerous times. With not only as we've just noted, would this have to be very, very quick, because if there's a pause in the amount of time taken to inject the air, then it's going to be aspirated in various ways. But also there's the question of how Lucy managed to do this without detection, without nobody else in an intensive care unit seeing her doing it. And certainly when I spoke to nurses about this, they considered it to be literally ridiculous. And then on top of that, there are even smaller syringes that are used in the case of the tiniest neonates and the infants that were being cared for and dealt with on this unit. And those syringes are smaller still. They are very, very tiny, and it becomes preposterous, really, that the physical act that will be required is actually conducted and carried out successfully. So with regard to this, many medical professionals are extremely sceptical regarding the logistics that would be required to inject a sufficient amount of air into an infant in the time frame possible without being detected by anyone else. So one nurse told me that this would require a large amount of air, more than could be possibly administered via a small syringe. And it must be emphasised that it's not a situation where you can just keep adding more air, adding more air, adding more air. Of course, the air that you've already theoretically injected, that would then go into the venous system. It doesn't just stay still. So like adding water to a beaker or a cup, for example. So you just pour in a bit of water, get some more water, pour some more in. It doesn't work like that, obviously. The venous system is constantly circulating. So if you were to inject air, that air doesn't hang around so you can add more air. It's just gone. So you need to be able to inject a large amount of air in a short period of time. And that just seems to be completely impossible from what I've been told. Even if you manage to inject the entire syringe of air, which is highly unlikely, it's practically logistically, I mean, that is literally logistically impossible, I would say. There's going to be a significant portion of the air that's not going to go where intended, for really obvious reasons. So you have to inject a significant amount of air per kilogram of weight to cause complications, and with such a small syringe, it's virtually unfeasible. You can see a cannula here, and this is what Lucy Letby was alleged to have used for some of these cases. So a neonatologist told the Daily Telegraph that a small amount of air in a thin syringe cannot make the difference in a circumstance such as this. So you can see this quote on the screen now. So this is a neonatologist speaking on the Daily Telegraph, and they speak about one case in their entire career in which there was an air embolism. They were resuscitating the baby, getting air out from the umbilical vessels, which were connected to the heart, which meant it was in the circulation. And that's a very, very rare instance from many, many infants that this person has treated. And they assert that just a small amount of air being inserted via a thin syringe will not make a difference. And bear in mind, this was just literally one instance of air embolism that this neonatologist had ever seen. So Dr. Evans admitted he'd never seen it ever. Dr. Burping said she'd never seen it ever. Other neonatologists said they've never seen it ever. There's one case here in which they did see one, and of course they just aspirated it and that was it. So it wasn't even particularly serious. Now Dr. Evans is saying Lucy Letby has managed to cause this in multiple infants across multiple collapses with a small syringe, where every other healthcare expert is saying this is impossible. So this is why we say the logistics of this case are just not feasible. Another instance of a neonatologists questioning the logistics involved in this theory. It's not a diagnosis, let's be clear on this. This is just a theory. This is a neonatologist speaking to Dr. Philip Hammond, who found that numerous experts considered the injection of air theory to be ridiculous, and the explanation for this is the same as one previously given. The tubes are tiny, and to inject enough to cause some sort of catastrophic result, I think firstly would take far too long, and secondly almost certainly be absurd. So you're seeing here that the logistics of this initial injection of air, they just don't work because you can't get enough into the veins in time for it to matter, and the chances of achieving a catastrophic result are minimal. The tubes are too small. The infant we're going to move on to seeing how the infant can get rid of the air from its anatomy as well. Then it can be aspirated out by doctors and nurses. Just the overall logistics of it, before you even go into looking at the fact there are other people on the unit, the overall logistics of it are just ridiculous. So this is why when The Guardian interviewed 8 neonatologists, they all said that it was not practically feasible for exactly the same reason again. Nasogastric tubes are tiny. It would take several refills using the 10 milliliter syringes that are on neonatal units to inject a significant quantity of air. Furthermore, it would leak out or the baby would burp or vomit it up or pass it as wind. So this is why we're seeing so many neonatal experts coming forward all saying, there's just no way. There's just no way. Of course, if Dr. Evans was qualified to be a neonatologist himself, if he'd done that during his career, perhaps he would be more privy to this sort of information that actual qualified neonatologists who are working now have come forward to say. For those people who don't know already, Dr. Evans has not worked in a hospital for nearly 20 years at this point in time. For those people that don't know, he never bothered to qualify to become a neonatologist. He was always a paediatrician. And I don't say that disrespectfully. A paediatrician is a very qualified medical expert, and I don't deny that. But a neonatologist requires an extra further 3 years of training. It's an extremely privileged position. In previous videos, I've demonstrated that there are less neonatologists in the country than Premier League footballers. Probably significantly less. It's a very difficult, very demanding position to reach, and they have very high level of specialised expertise. Dr. Evans did not have that. That's leaving aside the other problems that we've seen with Dr. Evans previously. But that is not the subject of this video. I just wanted to mention that very briefly. When I was interviewing for my book, one doctor that I spoke with told me that the theory is just essentially complete nonsense, because if there was high pressure developing in the stomach, it will just vent back up the nasogastric tube, or the baby will either vomit or burp the air back up. So this was indeed mentioned by the experts who spoke to The Guardian, who said numerous things, but furthermore the air would leak out, or the baby would burp or vomit it up or pass it as wind. It's very simple ways that air will be expelled. And then Professor Colin Morley, speaking with John Sweeney, was also speaking about this air injection theory. He said the following: there's various things. With baby C, the suggestion from a variety of people was that Lucy Letby inflated the baby's stomach with gas down a nasogastric tube. Now that might sound alright, but I think that it's totally improbable. Because you could put gas down there, but most of it would come up through the esophagus and be burped up. It's a hypothesis, a theory that he has come up with, but I've never seen anybody refer to it in any report or research paper, so it's just an idea that he and some of the people in Chester are trying to push. But I think they will never have seen it. Dr. Evans would never have seen it happen. I think they're just making it up. And then we also had the well-known neonatologist Dr. Svelina Dimitrova commenting on this in the Channel 5 documentary, where she said injecting lots and lots of air would be actually quite technically difficult to do, but even if this did occur, a competent team would have gone in, aspirated it out within the first couple of minutes of the resuscitation of the baby. So this is also corroborated here in Private Eye, where Dr. Philip Hammond is speaking with a neonatologist, and this consultant says babies get too much air in the stomach all the time with all the bagging and masking and CPAP, and all you do is take it out again. So he just essentially, he describes it as bollocks. He just thinks this theory has no basis whatsoever. And this is why the experts who spoke to The Guardian described it as rubbish, ridiculous, implausible, and fantastical. Now, at this time, Dr. Evans relied on the idea that the people involved didn't know what they're talking about or somehow hadn't seen information that he had. So he made this quote about, "It seems to be led by people with the least amount of information about the cases, people who had no access to the clinical records and were not there for the trial." Now, of course, he can't rely on that anymore because now there have been this panel of experts, the 26 neonatal experts that have been cited by Mark McDonald now. They've seen the clinical notes, they've been over all the infants, and they dismissed air embolism in every case in which it was cited in the conviction of Lucy Letby. So what we're going to do now is go over all of the infants and what was said about all of the infants in the preliminary panel reports. So in the case of child A, the panel cites new research showing that patchy skin discoloration has never been reported in infants with venous air embolism, including intravenous air injection. When air is injected into the veins, air bubbles must first traverse the lungs, where they are filtered out by a vast bed of small blood vessels. In infants, there is a hole in the heart, foramen ovale, that normally closes shortly after birth, so it is possible for air bubbles to escape through the hole into the arterial system. But Zhu and Lee reported no patchy skin discoloration in infants with IV injection of air. Patchy skin discolorations are caused by dilation and contraction of small blood vessels in the skin in response to hypoxia, which can occur in many conditions. So this is kind of an overarching assessment of why the only piece of evidence that was used in court and the only academic source that was cited has been cited incorrectly, and the only piece of evidence is worthless. So that is kind of an overarching aspect of all the injection of air cases, that the evidence used is just simply wrong. Moving on with child A, we discussed this antiphospholipid syndrome previously. This condition was present in the mother, and it can trigger the immune system into mistakenly creating antibodies that attack tissues in the body. These antibodies can trigger blood clots to form in arteries and veins. During pregnancy, antibodies can pass through the placenta to the neonate and lead to thromboembolism, particularly if there is concurrent infection. The post-mortem of baby 1 or child A showed a recent non-occluding thrombus in the liver, which means there was a recent thrombotic event. On the day of collapse, baby 1 or child A had 2 central catheters that were left without infusion for up to 4 hours, which predisposed to thrombosis when there is no infusion. Shortly after infusion was started in the most central line, baby 1 or child A collapsed. A thrombus from the catheter tip likely migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. It is also possible that baby 1 or child A had placental fetal vascular malperfusion, in which the fetal villi in the placenta present small thrombi that can travel to and occlude small blood vessels in major organs like the heart, brain, and liver. If a small thrombus lands in the artery supplying a critical structure like the brainstem, it can cause sudden death, and they are very hard to find on post-mortem. Collapse associated with fetal vascular malperfusion can occur 1 to 2 days after birth. Conclusions: baby 1 died from thrombosis. There was no evidence of air embolism. So there's very clear evidence of this absence of air embolism, but we also see the very forensic surgical investigation of this infant that contrasts significantly with the opinion and views of Dr. Evans. So move on to baby 2 or child B. On the day of collapse, baby 2 had a kinked and impacted long venous line which was not heparinized, treated with anticoagulants, and which can predispose to thrombosis. Thrombosis of long venous catheters occurs in 20 to 30% of infants, according to this systematic review that they've cited. The risk of thrombosis was further increased because mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies that attack tissues in the body and can trigger blood clots to form in arteries and veins. During pregnancy, antibodies can pass through the placenta to the neonate and lead to thromboembolism. The sibling, child A, that we've just discussed, suffered similar collapse and died 1 day after birth, and post-mortem showed a recent non-occluding thrombus in the liver, indicating a recent thrombotic event. Consequently, baby 2 or child B was at high risk for thrombosis. On the day of collapse, baby 2 had high D dimer of 6219 and low platelets of 103, both indicative of thrombosis. Fortunately, baby 2 survived, so we have no post-mortem evidence of thrombosis. So the panel goes on to say, patchy skin discolorations are caused by dilation and contraction of small blood vessels in the skin in response to hypoxia, which can occur in many conditions and are not diagnostic of air embolism. Zhu and Lee reported that non-specific localized patchy skin discolorations have not been reported in infants with venous air embolism, including IV air injection, and that only Lee's sign and Liebermaster's sign are diagnostic of air embolism. If air was deliberately infused through a central venous line to cause air embolism, the line will have to be reinfused with fluid to prevent detection. So this is yet another logistical reason why this can't have occurred. This idea that the line would have to be reinfused with fluid, which hasn't occurred on the unit. Collapse from air embolism occurs instantaneously. Obviously, we've discussed this several times. It is doubtful that this can be achieved quickly enough before other staff in the unit respond to the collapse, as we've mentioned previously. Conclusions. Baby 2 collapsed from thrombotic emboli originating from a central intravenous catheter, which was potentially aggravated by maternal antiphospholipid syndrome. There was no evidence to support air embolism. So in the case of child C and child D, I'm going to go over all the details just so you can see firstly how unwell these infants were, particularly in the case of child C, but in child D there were also numerous mistakes on the unit, but that infant was really struggling as well. But also how ridiculous, there are just clearly very obvious clinical signs that have just been completely discounted by Dr. Evans, and this becomes quite obvious when you see the opinion and views of the expert panel. So, baby 3 or child C was born at a gestational age of 30 weeks and 1 day. His intrauterine growth had been extremely poor. His birth rate was 800 grams. Average birth weight of a baby born at 30 weeks gestation is around 1.4 kilograms. And there had been reversed end diastolic blood flow, meaning abnormal blood flow. He was hence at high risk of intrauterine demise, stillbirth, and if live born, multiple immediate short-term and long-term complications. The decision to deliver him at a non-tertiary unit was therefore questionable. You could describe that as a generous assessment. It seems very clear that this infant should not have been born at the Council of Chester. By tertiary unit, they mean level 3. This is a level 2 unit that was obviously downgraded to level 1 and remains a level 1 unit to this day. He was cold on admission to the neonatal unit. He had low white cell and platelet counts, which are consistent with severe intrauterine growth restriction and not necessarily infection. He developed respiratory distress syndrome and was given surfactant. This is to help with breathing. Chest x-rays showed respiratory distress syndrome, not pneumonia, and that surfactant had been administered mainly into the right lung. Over the next 3 days, baby 3 showed multiple clinical signs of intermittent bowel obstruction, no bowel opening from birth, dark bilious aspirates, bilious vomit, intermittent stomach and small bowel distension, recurrent crying. No bowel movements and dark bowel aspirates and vomiting are clear indication for urgent surgical opinion. This did not occur. Instead, despite feeds being contraindicated, he was given a 0.5 milliliter nasogastric feed. He collapsed with a major apnea 15 minutes later. So I should say, with regard to this, that Professor Colin Morley was one of the people that has looked at this infant, and he cited a bowel obstruction as well. 2 nurses commenced resuscitation, one of whom was extremely inexperienced and had never done cardiac compressions before. The medical registrar who was called had 3 unsuccessful attempts at intubation before the consultant arrived. Baby 3 therefore would appear to have had ineffective ventilation for at least 20 minutes, which would have resulted in marked respiratory and metabolic acidosis and made subsequent resuscitative efforts less likely to be successful. He received 7 boluses of adrenaline, 3 of saline, 2 of sodium bicarbonate, and 1 of calcium gluconate. Following discussion with his parents, a decision was made to stop active resuscitation, but to continue ventilation until he was baptised. He lived for 5 hours following cessation of ventilatory support. Post-mortem showed an aberrant descending colon with persistence of the mesentery, a membrane that normally disappears in fetal life, thereby fixing the colon to the back of the peritoneal cavity. With a persisting mesentery, the descending colon is mobile and displaced to the right, with the potential for transmesenteric herniation of the small bowel to the left of the descending colon, causing obstruction that could be intermittent. Post-mortem also showed widespread hypoxic ischemic damage to the heart, lung immaturity, and other changes consistent with severe intrauterine growth restriction. It was alleged that air had been deliberately injected into baby 3 through the nasogastric tube, sufficient to cause his collapse. Baby 3 did not respond adequately to prolonged resuscitation because of inadequate resuscitation for 20 minutes following an acute episode of apnea. Recovering respiratory distress syndrome and severe growth restriction with myocardial ischemia would have further added to the likelihood of a poor response to resuscitation. The apneic attack was likely precipitated by severe pain due to a further episode of acute small bowel obstruction, precipitated by feeding. The suggestion that the multiple signs of intestinal obstruction could be caused by injection of air through the nasogastric tube is untenable. Baby 3 died because of a decision to discontinue respiratory support and resuscitative effort in the face of a poor response following inadequate resuscitation for at least 20 minutes after an acute episode of apnea. The clear prior signs of intermittent bowel obstruction that warranted urgent surgical opinion and investigation had gone unrecognised, and indeed they were unrecognised by Dr. Evans. So you can see in this summary that there's a very clear clinical explanation for what happened to this infant. Now that's very important because in the court case, as we saw, if you go through the process that occurred in court, either court reporting or court transcripts, it's clear that they just tacked this on to the original diagnosis for child A and child B, citing the supposedly same skin conditions and physical presentation, even though it's not actually the same, and completely ignoring all of these really obvious signs of bowel obstruction and massive intestinal issues. So I'm also going to go over the full details of child D because there was also a very clear clinical picture with this infant which indicates that it's nothing to do with air embolism. So child D was a 37 plus 1/7 week, 3.13 kilogram birth weight female infant who was delivered by emergency caesarean section for failed induction of labour after prolonged premature rupture of membranes. The APGARs were 8 at 1 minute, 9 at 5 minutes. At 12 minutes she became pale and floppy and needed respiratory support with bag and mask. So remember that in an Australian documentary, Dr. Evans stated that none of these infants required respiratory support. So this infant that collapsed 12 minutes into her life, just checking it's a female, so her life, becoming pale and floppy, clearly on the verge of death, clearly required respiratory support just to be kept alive, but according to Dr. Evans in this documentary, none of these infants required respiratory support. So it's hard to see how that could be described as anything other than a deliberate untruth. It's not just a mistake, or it's not just someone being mistaken, it's completely misrepresenting the condition of these infants. So child D, or baby 4, was admitted to the neonatal unit 3.5 hours later. She was cold, blue, dusky, and had respiratory distress, polycythemia, and infection, high white cell and neutrophil counts. So again, this infant has respiratory distress. It couldn't be clearer that this infant has respiratory problems. It couldn't be any clearer. The first blood gas taken 4 hours after birth showed high CO2 and respiratory acidosis. Continuous positive airway pressure was started nearly 4 hours after birth. It's a form of respiratory support, of course. She was electively intubated after 3 attempts and ventilated. Chest x-ray showed pneumonia. The following day she developed fever, deteriorating blood gases, and increasing metabolic acidosis. The next day she was mottled and had dark brown and black tracking lesions across the trunk and 2 evolving purpuric-looking patches on the abdomen. She had prolonged coagulation times, raised CRP, and repeated episodes of apnea and desaturation until final collapse and death. It was alleged that baby 4 was a stable infant who died from injection of air into the intravenous line, causing air embolism resulting in collapse, patchy discolorations of the skin, and death. In December, so this is going over something that we've already looked at, but I will go over it again. In December 2024, Zhu and Lee published new research showing that patchy skin discolorations have never been reported in infants with venous air embolism, including IV air injection. When air is injected into the veins, air bubbles must first traverse the lungs, where they are filtered out by a vast bed of small blood vessels. So I'll continue from new material here. The mother should have been given antenatal antibiotics for prolonged premature rupture of membranes in a preterm infant. NICU admission, neonatal intensive care unit, blood gas and CPAP were delayed for 3 to 4 hours, and chest x-ray was delayed for 6 hours, which subjected the infant to unnecessary acidosis, high CO2, and delay of antibiotic treatment. The infant continued to deteriorate after admission and showed signs of worsening infection with fever, intolerance of CPAP removal. So as soon as they took away breathing support, the infant struggled. So much for this infant not having any respiratory problems. Deteriorating blood gases, increasing metabolic acidosis, raised CRP, and repeated episodes of apnea and desaturation. She developed prolonged coagulation times, which indicate the infection was going out of control and causing early disseminated intravascular coagulation. The acronym for this is DIC, so it continues with DIC from now on. DIC causes coagulation in the blood vessels, coagulation defect, and bleeding. Coagulation defects do not occur with air embolism. The patchy skin discolorations were caused by DIC causing clotting in the small blood vessels of the skin, which compromised blood flow, which together with hypoxia triggered dilation and contraction of small blood vessels in the skin, resulting in patches of skin discoloration, purpuric patches, and tracking lesions. Conclusions: baby 4 died of systemic sepsis pneumonia and disseminated intravascular coagulation. The mother should have received intrapartum antibiotics. There was delay in recognising respiratory distress after birth and starting antibiotics and treatment, and there was no evidence of air embolism. So again, this is another infant with very clear clinical signs that just cannot be tacked on as another case involving air embolism in which they've used skin discoloration wrongly yet again. It's just really poor evidence and really poor medical work. It's even generous to describe it as medical work, frankly. This is just the concoction of theories so that there's a court case, as far as I'm concerned. And that's why you've got so many medics, so many neonatologists coming out and, as I say, dismissing this theory and dismissing the evidence that was put in the court case. So, baby 5, or child E, was at high risk because he was preterm, had twin-twin transfusion with oligohydramnios, and his antenatal ultrasound showed reversed end diastolic flow and dilated small bowel loops. This meant blood was being sucked out of the fetus at the end of each cardiac cycle, and the intestines were likely damaged before birth. The 2 episodes of massive gastrointestinal hemorrhage were most likely due to in utero hypoxia causing stomach or small intestinal ulceration, an erosion into an intestinal blood vessel, or to a vascular abnormality like Dielophoid's lesion, which can cause life-threatening hemorrhage. His 25% blood volume loss was likely an underestimate because more was likely lost in the intestines. So that's obviously very significant. I recently discussed the closing statement of Nick Johnson with regard to Child E, and we saw that this gastrointestinal hemorrhage is obviously, well, it's critical, isn't it? I mean, it's obviously critical in this infant, and what was put in the court case is ludicrous. And that's at an actual 25% blood volume loss. 25% blood volume loss for an adult is potentially fatal. If you're not treated adequately, you will die. If you're treated adequately, it should be fine, but it's still a very serious situation for a fully grown adult. 25% blood loss for a neonate is immediately hugely dangerous. It has to be dealt with correctly and it has to be dealt with swiftly, otherwise the infant will simply die. On top of that, this is more than 25% blood loss. So this is an enormous amount of blood loss, and the infant was immediately hugely vulnerable. And even in a competent unit, this infant may have died just from that blood loss. As is, this infant was not in a competent unit. Emergency transfusion with group O negative blood should have been immediately given earlier during resuscitation. It's hard to imagine how they dillied and dallied on this transfusion, as we know they did. Inexplicable, really. Since 20% of blood loss causes shock and baby 5 lost much more, this was fatal. Patchy skin discolorations are caused by dilation and contraction of small blood vessels in the skin in response to hypoxia, which can occur in many conditions and are not diagnostic of air embolism. Zhu and Lee reported that non-specific localized patchy skin discolorations have not been reported in infants with venous air embolism, including IV air injection, and that only Lee's sign and Liebermeister's sign are diagnostic of air embolism. If air was deliberately infused through a central venous line to cause air embolism, the line will have to be reinfused with fluid to prevent detection. Collapse from air embolism occurs instantaneously. It is doubtful that this can be achieved quickly enough before other staff in the unit respond to the collapse. In conclusion, baby 5 died from massive gastrointestinal hemorrhage due to either intrauterine hypoxia causing stomach or intestinal ulceration or a congenital vascular lesion. Emergency blood transfusion should have been given much earlier. There was no evidence of air embolism. Post-mortem should have been requested. Again, this is a rather facile conclusion when you look at the clinical picture related to this infant, let alone one that world-class neonatologists can draw from looking at the clinical notes. The next infant we're going to look at is baby 9 or child I. We're going to go over the full details of this infant because this was another very vulnerable infant. So baby 9 was a 27-week, 970 grams, so less than a kilogram, smaller than a bag of sugar, 12 to 13 weeks, born 3 months before its full gestation period. This female infant is immediately extremely vulnerable. Obviously, as well, then is mentioned that this infant has intrauterine growth restriction, making it even worse. Then born after premature rupture of the membranes at Liverpool Women's Hospital, making her even more vulnerable. Treated for mild respiratory distress syndrome with respiratory support and antibiotics. So this infant, according to Dr. Evans, didn't have any breathing problems, didn't require any oxygen, didn't require any respiratory support. For sepsis began on day 1 of her life, with intravenous and enteral feeds by oral tubing. She developed bradycardias, respiratory distress and elevated white count, leading to her first of 5 transfers to 4 hospitals on day 12 of life. Obviously, very suboptimal care. She developed chronic lung disease, abdominal distension, and recurrent episodes of apnea, desaturation, and bradycardia, requiring resuscitation and ventilation. She had viscous gelatinous secretions from her airway and mouth that were associated with frequent blockages of her endotracheal tube and sticky stools. A registrar stated that it's not unusual for babies on breathing support to get secretions, but it was a bit unusual for them to be so stubborn at being removed. Testing for cystic fibrosis was sent. She had an episode of lung collapse. At 2.5 months, she had an episode of severe apnea, bradycardia, desaturation, and heart block, and deceased. So we can say, in the case of child I or baby 9, that this was a chronically unwell infant that's facing numerous very serious problems, and for it to be presented in court as if this infant was perfectly well and that the collapse was completely unexpected and that this infant would have been expected to just go home without any problems is pretty ridiculous. I would say even embarrassing. It was alleged that air was injected into baby 9's stomach via a nasogastric tube, leading to recurrent episodes of abdominal distension. So if you look at everything surrounding this infant, what is the chance that the injection of air into the stomach via a nasogastric tube was actually required to create the clinical picture that you can see with this child, leading to recurrent episodes of abdominal distension, splinting the diaphragm and respiratory arrest? Of course, Dr. Evans has now jettisoned this explanation in favour of a new explanation that is equally ridiculous. Obviously, this happened after the court case. On the 13th of October 2015, it was alleged that the apnea alarm was deliberately turned off, resulting in delay in response to a collapse. On the 15th of October 2015, it was alleged that air was injected into her intravenous tubing, causing air embolism and death. Baby 9 was a very preterm intrauterine growth restriction infant with respiratory distress syndrome and chronic lung disease. Stenotrophomonas multifilia was detected in surveillance cultures from her endotracheal tube. Stenotrophomonas multifilia is a multi-resistant opportunistic pathogen that can colonize the airway in biofilms that are resistant to antibiotics and generally impossible to clear in patients with chronic lung disease. The thick secretions can block endotracheal tubes and interfere with ventilation in these small airways of these vulnerable infants, which together with other factors like chronic lung disease lead to recurrent episodes of apnea, desaturation, bradycardia, respiratory failure and collapse. Stenotrophomonas multifilia colonization would have further compromised her ventilatory capacity. The initial abdominal distension was likely due to sepsis, causing ileus, or to lactose intolerance, as there was a family history and stools were positive for reducing substances. The repeated abdominal x-rays showing intestinal gaseous distension were all taken after resuscitation, and air was likely introduced by bagging. A nurse explained that the reason the apnea alarm did not sound was because the apnea alarm goes off if there is a 20-second period of no breaths, but because she was gasping and it was less than 20 seconds, it hadn't gone off. There is no evidence that embolism was involved. Baby I was not treated for Stenotrophomonas multifilia. So it's very important to note, because this Stenotrophomonas is a critical aspect of the picture of this already very unwell infant. The lawyers from the Thirl inquiry claimed that this had been ruled out by testing, but I've shown in a previous video that this is just completely untrue. It's very easy to actually demonstrate this is untrue. There's just no way that they recognise this. And indeed, they would have tested for it, they would have found it, they would have treated this infant, but they did none of those things. Conclusions. Baby 9 died of respiratory complications caused by respiratory distress syndrome and chronic lung disease complicated by Stenotrophomonas multifilia colonization. The doctors failed to respond to surveillance warnings about Stenotrophomonas multifilia, did not recognise the diagnosis, and did not treat it with the appropriate antibiotics. This was a likely preventable death. There is no evidence of air causing splinting of the diaphragm or of air embolism. There is evidence that the apnea alarm was not turned off. So again there we have a chronically ill infant that suffered a lot, but even then they say this was a preventable death. If the unit had actually responded adequately, if they'd identified Stenotrophomonas, then this infant could have survived. But they just didn't. They didn't test for it. We know for a fact they didn't test for it. So this was an absolute failing of the unit. And the idea that this infant died due to the splinting of the diaphragm from an air embolism is just... I mean, you can choose your adjective. Absurd, ridiculous, surreal, embarrassing. One of those. So moving on now to baby 13 or child M. This infant had signs of possible sepsis from birth, including jaundice requiring phototherapy and hypoglycemia, and was treated with antibiotics. The next day he clinically deteriorated for 4 hours prior to collapse, with abdominal distension, increased work of breathing, raised temperature and bile-stained NG aspirates, and which were of concern to the nurse and registrar. The acute episode of desaturation and bradycardia was likely triggered by apnea from sepsis, abdominal distension with ileus, and prematurity. It could also be due to the cardiac eustachian valve, which can cause episodes of desaturation and bradycardia due to intermittent right to left shunting of blood through the foramen ovale. The resuscitation was chaotic, with adrenaline times x2, so it just means double the usual strength, I believe, doses given before the airway was secured. Air embolism is sudden and catastrophic and does not present over 4 hours with gradual deterioration, and the infant would not recover quickly. So, I mean, immediately that sentence can rule out air embolism completely in this case. Patchy skin discolorations are caused by dilation and contraction of small blood vessels in the skin in response to hypoxia, which can occur in many conditions and are not diagnostic of air embolism. Non-specific localized patchy skin discolorations have not been reported in infants with venous air embolism, including IV air injection, and only Lee's sign and Liebermeister's sign are diagnostic of air embolism. If air was deliberately infused through a central venous line to cause air embolism, the line will have to be reinfused with fluid to prevent detection. Collapse from air embolism occurs instantaneously. It is doubtful this can be achieved quickly enough before other staff in the unit respond to the collapse. Conclusion: Baby 13's desaturation and bradycardia was caused by apnea from sepsis or the eustachian valve. The resuscitation was suboptimal. There was no evidence of air embolism. So, very clear clinical picture in relation to child M. Frankly, again, it's ridiculous to suggest that this has anything to do with an air embolism. This is why no experts have come forward since the court case to support any of Dr. Evans' whether you want to call them hypotheses, theories, concoctions. They're certainly not diagnoses. So this is child O, or baby 15. This infant collapsed because the subcapsular hematoma ruptured. So this there was very clear evidence of a subcapsular hematoma, and that was mentioned in the pathology reports for this infant. It's quite incredible that this was overturned and the presence of this subcapsular hematoma was completely downplayed in court. So the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity, sufficient to cause a near halving of the hemoglobin level. Subcapsular liver hematoma is the result of traction or shear forces applied to the thin, fragile liver capsule through the hepatic ligaments. In baby 15, this was likely the result of the extremely rapid delivery, which is a well-recognised cause of birth injury. Bleeding into a subcapsular hematoma is characteristically initially slow because it is contained by the pressure of the enveloping liver capsule. In these early stages, the clinical signs are insidious and difficult to recognise. High-pressure ventilation decreased venous return to the heart and contributed to liver congestion. The slow deterioration is then characteristically followed by acute collapse when the capsule ruptures, releasing free blood into the peritoneal cavity. The significance of the rising heart rate and falling pH before the terminal collapse were not recognised, so more mistakes on the unit. The blind abdominal insertion of a needle during resuscitation may have penetrated the right lobe of the liver, causing further injury, noted by the pathologist as parenchymal hematoma and laceration. Blunt direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in a liver protected by the lower chest wall. The gaseous distension of the intestinal tract was likely due to air swallowing and insufflation during non-invasive respiratory support. Of course, none of these infants were receiving respiratory support, as we know from Dr. Evans. The suggestion of injection of air into the circulation is conjecture, which is a generous description. Baby 15 died from a subcapsular liver hematoma caused by traumatic delivery, resulting in hemorrhage into the peritoneal cavity and profound shock. This was not recognised ante-mortem. So we'll move on now to the final infant we're going to look at, the last one where there's a allegation of the injection of air, which is baby 16 or child Q. The initial gaseous distension of the abdomen was caused by CPAP and not by injection of air into the nasogastric tube, so this is another infant receiving respiratory support. It is unclear whether the nasogastric tube was open to drainage. Baby 16's care after the collapse on 24th of June was mismanaged, and there were unacceptable delays in recognition and treatment of the pneumothorax, yet another medical blunder. Delay in treatment of the pneumothorax led to persistent metabolic acidosis because of persistent poor circulation and gas exchange caused by the pneumothorax. It is unclear whether the pneumothorax preceded or followed the resuscitation. Pneumothorax can occur in preterm infants with mild respiratory distress syndrome, especially with CPAP or other respiratory support, or even without any lung disease or respiratory support. The medical records do not show that a cold light test was performed. He was treated with high pressure ventilation and adrenaline despite having no lung disease and requiring only 26% oxygen. Both are harmful because high ventilation pressures impede venous return to the heart, resulting in worsening circulatory failure, and adrenaline punishes the heart by overworking it unnecessarily. There were no signs of air embolism at final collapse. Conclusions: baby 16 died from pneumothorax that was suboptimally managed. There was no evidence of air injection into the stomach or into the intravenous line. So those are all the cases in the court case in which it was alleged that Lucy Letby injected air. As you can see, the clinical picture for all of these infants is such that it can be almost completely ruled out, even if it were not the case, that the signs, i.e. the rashes and discoloration that have been used to diagnose this, are completely incorrect, and this was passed on from one infant to the other in this court case, and despite the fact that the one diagnostic paper that was used to diagnose this was used incorrectly, and Dr. Evans incorrectly diagnosed the rashes and then used the rashes that were different in all these cases as one kind of unifying factor that the gentleman who wrote that paper has now come out and completely dismissed. So when we look at the picture of all these infants, we're obviously talking about the logistics of air embolism, the injection of air into the nasogastric tube in this video. That is already basically impossible. It looks like it's completely clinically impossible. Even if you had an empty unit with no one ever coming in and out, you had an infinite amount of time, it's probably still impossible. Although why you would do it under those circumstances when you can just smother the infants, I have no idea. In a neonatal unit in which it's very busy, there's lots of nurses around, there's lots of people working on the unit, there's lots of doctors, registrars, parents are coming in and out. The idea that Lucy Letby's reached into the incubator, picked the infant out, multiple injections of air, in a methodology that may be ergonomically impossible anyway, is just an absolute, it's a complete fantasy. It's total rubbish. That's why so many neonatologists have come out and said that it is rubbish, because they know it's rubbish. It's as simple as that. And we see, when we look at the medical picture for these infants, that there are just far more compelling reasons why these infants collapsed and in some cases unfortunately died. So I spoke to numerous neonatal nurses regarding these allegations, and they all told me that these units are extremely busy. You're very rarely in a nursery on your own. There are other nurses around, there are doctors around, there are parents coming in and out of the unit regularly. And the idea of being able to do this across multiple infants undetected, the likelihood is just essentially non-existent. It's just not possible. So that's a very critical logistical aspect of this case that just simply was not considered in court. Now, in order for the prosecution to even suggest that this was remotely possible, they had to try to pinpoint the odd moment where they could say, oh look, Lucy Letby could have been alone at this point for a certain, maybe a couple of minutes or maybe a few minutes, possibly. And that's based on, they literally had to pour through the records to try to pick something together. And they had to use all manner of fabrications and inventions in order to do this I will continue to expose on this channel. If you've watched the closing statement, you'll see how poor it is, how poor the prosecution case was, how many holes there are in the prosecution case. The prosecution in the closing statement has misrepresented things, fabricated things on numerous occasions, and outright lied. And I wouldn't say that they'd outright lied lightly, but they did lie already in that speech. I'm sure they'll lie again, but they definitely lied so far. And that's necessary, just to be able to concoct this ridiculous narrative they put together when there are for example, as we looked at Child E in the previous video, and Lucy Letby called the doctor, and this infant, as we just mentioned, this is Child E or Baby 5, was suffering with a very obvious and massive gastrointestinal hemorrhage. Now somehow Dr. Evans has put that infant in the court case and said that Lucy Letby caused this with an air embolism. So, and maybe some sort of tool although he had to change that several times. So the prosecution then has to come up with some sort of theory to make this plausible. So they've got to do all kinds of ridiculous things in order to do that, as we saw in the previous discussion. And this is before all of this that we're discussing now, all these logistics. That's before we take into consideration the fact that all the swipe card data is wrong for this court case. An enormous amount of it is not reliable. They didn't have a lot of swipe card data available, aside from the fact that we know a lot of it was reversed. And then on top of that, the prosecutor himself pointed out that people can just walk in and out of doors without swiping. He put that to Lucy Letby because at some point Lucy Letby said, but I know that I was in this place. And he said, well, you might not be because you could have sneaked in behind someone else. So that renders all of the prosecution case worthless immediately. Just immediately we know you can't say anyone is anywhere at any time because Nick Johnson has just admitted anyone can just walk in and walk behind someone else and there you go, we don't even know where you are. That's before the exit in the nursery that exists as well. So there's an exit in the nursery where you can just walk out without swiping. So this is highly dubious data, and all of this had to be used to try to concoct some scenario in which Lucy Letby could feasibly be on her own, although realistically, even then, parents can walk in. We know other nurses can be present and not have swiped. There's doctors coming out all the time. We don't even know doctors have left because in certain nurseries that there is an exit without a swipe card. They could have gone out without someone else. All kinds of things could have happened. It's absolutely ridiculous to go back 6 or 7 years in time and then literally they're going through all this data, much of which is incomplete, incorrect, flawed, and then trying to say, oh, but according to our records, this could have happened at this moment, and then despite all the logistical issues, Lucy Letby must have injected air into the infant at this moment. It's bullshit. It's absolute bullshit. Then on top of this, we also know that Lucy isn't present for numerous deaths now, and numerous collapses, I should say. We know this because of the Unheard article. There's at least 10 collapses that she was linked with that she's not on duty and not present. And then there's numerous other collapses on the unit as well. So there's been 18 deaths. There are multiple collapses of multiple infants. Lucy isn't around for many of these collapses. And I've shown in previous videos that the infants that are not included in the indictment and the infants that are included in the indictment are virtually interchangeable. It's also notable, and as I've mentioned previously, that 3 full-term infants died on this unit that were not in the indictment. So there's one that's, I believe the 2 of them are 39 weeks and one of them is 40 weeks. So they've been through the full gestation period. They all died on this unit. So the idea that deaths don't occur on this unit unless Lucy Letby is around is just palpably absurd. So here's a brief list of the experts that have gone against the injection of air and air embolism theory. It's not a diagnosis. Let's make that crystal clear again. This is just some hypothesis. It's generous. It's generous to describe it as a hypothesis because a hypothesis indicates some sort of scientific rigour. It's just something that Dr. Evans has concocted out of nothing, and that's why no one who has qualifications takes it seriously. So that's why there's 26 experts in Mark McDonald's panel, several other experts who've worked with Mark McDonald, including Svelena Dimitrova, Neil Layton, Richard Taylor and Colin Morley, 8 experts, including 7 neonatologists who spoke to The Guardian, further experts who have spoken to The Guardian since then, yet more experts who've spoken to the Daily Telegraph, and yet more experts who've spoken to Dr. Philip Hammond, who all say the injection of air theory is complete rubbish. So in summary, removing the sterile packaging from syringes without detection on the multiple occasions required by the prosecution case seems immediately implausible. A plethora of experts have dismissed the possibility that a small syringe can be used to deliver a fatal dosage of air. This opinion has been corroborated by numerous nurses that I've spoken with, many of whom believe that it is logistically impossible. Many nurses also consider it unthinkable that such attacks could be conducted in the time frame required without detection, considering the logistics involved. Many experts have also asserted that an infant is likely to simply burp out excess air or that it would be aspirated by a team of doctors and nurses. Literally dozens of neonatologists, along with many other experts, have come forward to refute the injection of air theory of Dr. Dowie Evans. When a panel of neonatal experts examined inference from the Letby case, they found no evidence for any form of air embolism being significant. Finally, Lucy is often not present when collapses occur, immediately ruling out air embolism, or there are many other people around her, making the undetected administration of such an attack literally impossible. Finally, as we see Lucy here in happier times, I just want to emphasise that this is just one small portion of the picture related to the air embolism cases. This is just about the logistics and how they are essentially logistically impossible. There's a lot more to this alleged act than can be contained in this video, and I will be making many more videos about the injection of air / air embolism cases as the weeks and months unfold. I'm sure that I'll make at least 8 or 9, maybe more videos on this topic, because there's so much that went into the court case that is wrong. It's just plain wrong. This is just one aspect of it. Just want to mention as well, just a couple of things to end. Firstly, if you've enjoyed watching this video and you're not subscribed already, it would be very much appreciated if you could subscribe. I've been incredibly well supported and I'm enormously grateful for that. But the more subscribers you get, the more visible it makes your channel, the more YouTube shows your video to other people, the better it is. So if you did enjoy this, if you could subscribe if you haven't already, that would be greatly appreciated. And lastly, I've started to post on Twitter. I had a previous account I'm going to discontinue. So this is my account that will be properly verified soon, even though it isn't currently, but I will verify it at some point. It's just at cpmorris1234. I'll try to post some actual writing and posts on there at some point. But yeah, I'm trying to just steadily build a following, even though I'm not the biggest fan of Twitter. So if you feel like following me, then that'd be great. So that's it for this video. Thank you very much for watching and for all your support. I look forward to reading your comments. If you have any queries or questions, please do ask.